Good afternoon, ladies and gentlemen. Allow me to share the preliminary results of our study on the etiology of sexually transmitted infections in Zimbabwe, specifically looking at HIV infection amongst patients with STIs. Sexually transmitted infections continue to place a significant burden on both developed and developing countries, with important reproductive health consequences such as pelvic inflammatory disease, ectopic pregnancy, as well as subfertility. The presence of STIs amongst persons with HIV may act as a marker of transmission risk. Thus, knowledge on the occurrence of STIs and HIV informs prevention among high-risk populations. In Zimbabwe, as in many other developing countries, laboratory testing for etiologic agents is largely unavailable. As a result, STIs are reported based on symptoms. The surveillance of STIs remains key priority in public health, but needs laboratory support to determine etiologic agents for use in developing treatment guidelines. We thus set out to determine the prevalence of HIV amongst STI patients in Zimbabwe with these questions in mind. What are the causes of STI syndromes in Zimbabwe? And what is the prevalence of HIV amongst these syndromes? Our broad objective was to determine the current etiology of sexually transmitted syndromes in Zimbabwe. There were 7 specific objectives in this study, but the focus of this presentation is specific objective number 5, which reads, to assess the prevalence of HIV amongst patients presenting with sexually transmitted syndromes in Zimbabwe. We enrolled 600 men and women, where 200 were men with urethral discharge, 200 were women with vaginal discharge, and 200 men and women with genital ulcer disease. Patients were conveniently enrolled into the study as they presented for care at 6 purposefully selected sites in Harare, Bulawayo, Beitbridge, and Gutu. Written informed consent was obtained from all patients for interview, sample collection, HIV testing, and sharing of results. An interview-administered questionnaire was used to collect information on social demographic characteristics. This was followed by clinical examination and collection of samples. Permission to proceed was sought from the Ministry of Health and Child Care, the Medical Research Council of Zimbabwe, the Research Council of Zimbabwe, and Centers for Disease Control and Prevention, Atlanta. Samples collected include genital swabs, blood, urine samples, and ulcer swabs. All samples were transported using overnight courier services to Zichire Laboratory at Wilkins Hospital, where samples were tested or packaged. Packaged samples were subsequently sent for testing at the University of Zimbabwe UCSF Laboratory, at Flow Cytometry Laboratory in Harare, and STI Reference Laboratory at the National Institute of Communicable Diseases in South Africa. Gram stain, HIV testing, and syphilis testing were done at Zichire Laboratory. HIV testing was done using the current Zimbabwe National HIV testing algorithm. Testing of urine samples and swabs is being conducted for these organisms using PropTech at UCSF, GeneXpert at Flow Cytometry, and multiplex polymerase chain reaction at NICD. And now, ladies and gentlemen, our results. This study is still ongoing, with data available for 416 out of 600 enrolled patients. Because we are working with different laboratories both in Zimbabwe and South Africa, some test results are not yet available. Out of the 416, 371 agreed to have an HIV test done. The following are available for analysis: 360 treponemal test results, 250 results from PopTech, 70 multiplex results, amongst others. This table shows HIV prevalence by demographic and syndromic category. The mean age of HIV-positive patients was higher than that of HIV-negative patients. There was no difference in the HIV prevalence between men and women. The prevalence of HIV varied, ranging from 30% in men with urethral discharge syndrome and to 56% amongst women with genital ulcer disease. About 12% of HIV-positive patients tested positive for chlamydia as compared to 20.3% of HIV-negative patients. HIV testing and syphilis treponemal testing was complete for 360 patients. Amongst these, 19.3% of HIV positive patients tested positive for syphilis as compared to 7.9% of HIV negative patients. This difference was statistically significant. 15.5% of HIV positive patients and 8.9% of HIV negative patients tested positive for rapid plasma reagin. 24% of HIV positive patients tested positive for treponema pallidum as compared to 2.7% of HIV negative patients. And please note, these are results for genital ulcer swab. Of 105 patients who self-reported HIV negative, 13.3% were found to be HIV positive. 29% of 156 patients who did not know their HIV status were HIV positive on testing. Conversely, of the 108 patients who self-reported to be HIV positive, 17% turned out to be HIV negative. All participants with discrepant results are being followed up. In our discussion, the overall prevalence of HIV was above 30% for all syndromes, whilst being highest amongst patients with genital ulcer disease. This is plausible considering that ulcers and inflamed areas provide an easy port of entry for HIV. The positive association between HIV and prevalence and STIs has been demonstrated in several studies throughout the world, where it has been noted that similar behavioral patterns put people at risk of both infections. This calls for the need to screen for HIV in STI clinics as well as outpatients departments. A substantial proportion of patients who reported unknown HIV status were positive. Some of these patients may have known that they were HIV positive, but were reluctant to share their results. On the other hand, they may also have been engaging in risky behavior and were thus afraid of getting an HIV test. The association between HIV and incident gonorrhea and syphilis is significant, as it may indicate high-risk sexual behaviors leading to both HIV and other STIs. High risk of ongoing HIV transmission amongst those with pre-existing HIV infection and new STIs. Thus, patients presenting with STI symptoms comprise a critically important population in the continued spread of HIV and should therefore be a major focus of HIV prevention efforts. Our limitations in this study include incomplete data on laboratory results, which resulted in wide confidence intervals for some analysis. Only patients with symptomatic STIs were studied in this study. Therefore, a large pool of patients with STIs are not represented here. Selection of patients in clinics that provide HIV care could have resulted in oversampling of HIV-infected patients, resulting in the high prevalence of HIV. In our next steps, we plan to complete data analysis as soon as the results come back from the laboratories. Patients who were partially treated for STIs during the study are being followed up and appropriate treatment being given. Patients with discrepant HIV test results are being followed up for retesting. We would recommend that the country consider a large-scale study to inform national STI syndromic management guidelines. This is the list of team members who participated and continue to participate in this study. This study was conducted as a collaboration between the Ministry of Health and Child Care, the University of Zimbabwe Department of Community Medicine, and the Centers for Disease Control and Prevention Zimbabwe, with funding from PEPFAR. Ladies and gentlemen,